Yes, coming to another very important facet of post-op complications, how to communicate to a patient about a complication that has been caused, but elsewhere. When the patient comes to you for a second opinion, how do you deal with that? So, Dr. Grover, sir, what would be your opinion on this?
I think that is one very critical area in the context of what has been discussed so far about the medical legal issues. And the important thing is that you communicate honestly to the patient that there is this problem in this eye at this moment, and totally avoid being judgmental, even by um, a hint of suggesting that something could have been done better. That is the most important thing, because patients would very often directly ask you, do you think it has been done well, or do you think this could have been done better, or that this has happened because, yeah, jaise Dr. Somashela said, meri aankh kharab karke bhejiye, or something like that. So then um, your communication has to be very clear that this is the difficulty in the eye at this stage, but you do not know what circumstances that pre-existing conditions the patient had, what circumstances were present at the time of surgery, which led to which led to the current result, which or led to भी कहना गलत हो जाता है, which may explain what the result is like. But you have to really say that every surgeon does his best, and the result cannot always be 100%, which is true for the most experienced of the surgeons and by the best of the people. So that is what needs to go out very, very well, and it has to be communicated not just in your language, but in the way you talk to the patient, in the way you convey with your body language. I think that is extremely vital, and that is something which you learn with experience, that this is such a critical aspect of dealing with a patient with difficulties or complications.
Thank you so much, sir. Some very valuable points. Dr. Shreyas, how would you manage such a patient who comes for a second opinion?
I manage a patient who comes for a second opinion or referred in the very much in the same way as if I had the same complication myself. There's no difference. I would be reasonably honest upfront, of course, without scaring them or without put it in a nice way and highlight the fact that they can have a very good prognosis at the end of the day. I think the problem arises when the primary surgeon has not been upfront or honest with them. That's where you actually kind of get into trouble. And I've noticed this happening as a cornea surgeon in patients with pseudophakic bullous keratopathy, where you are explaining to them they have a decompensated cornea, why they have a decompensated cornea, and what you can do to rectify it. And actually, now with DMEC, we are able to give them excellent results, almost as good as what they would have after the primary cataract surgery. But then, if the primary surgeon has kind of tried to dissociate it by saying that the cataract surgery had nothing to do with the problem, saying the lens is all fine, everything is normal, and it's just your cornea has a problem, you go and get your cornea problem rectified. That is where it leads to trouble. And if it has been referred, definitely I talk to the referring surgeon first before seeing the patient, and understand what they have told the patient, and then subsequently see the patient and talk to them.
Thank you, sir. Dr. Gaurav, any of your thoughts on this matter?
Yeah, thanks, Archika. So I think the principles remain the same. Most importantly, as Dr. Grover said, don't be judgmental. And it's very easy to be judgmental, and so many times you realize later on that the primary surgeon probably was dealing with a very tough situation, and we don't even know what was the primary situation. So it's best not to kind of call judgment, and it's good to tell the patient as well that maybe your surgeon did the best, and maybe your eye had a situation, but sometimes you will also come across a gross complication of, for example, you'll probably notice a badly done surgery, a panoptics put in the sulcus with inflammation, and then it becomes a very difficult situation on how to, because you have a responsibility to the patient as well. And frankly, at that point, then you have to take a call without actually blaming the primary surgeon. It's also sometimes your responsibility to tell the patient about what might be best for the patient at that point, and maybe hint a little bit at what can be done, or so I think it's a very tightrope kind of a situation which you have to walk, because you don't want to blame your colleagues, especially when you don't know what they were dealing with. And second thing, that you have a responsibility to the patient. So I think best thing is to follow what principles Grover sir said, that tightrope of trying not to blame anybody unnecessarily without knowing anything, and yet making sure that the patient gets the best outcome, and also kind of showing them the brighter side of what can be done with them. So I think that would probably be the best way.
Thank you, sir. Dr. Somashela, ma'am, what are your thoughts? Do you think that talking to the primary surgeon in this matter would better help communicate with the patient regarding what went wrong?
Yeah, so I think you can call me complication referral queen because a lot of alumni do send to me, not that they had a complication because of lack of skill or something like that. As was already pointed out, it's because the eye anatomy may be difficult. And so we get a lot of cases like Shreyas does with corneal decompensation requiring surgery and so on. So then outright, I just tell sometimes, as Gaurav said, sometimes it's very difficult, but I just sort of lie through my teeth, so to speak, because I don't want the patient, again, coming to the psychology for the patient, and this is important for the patient's healing. So one thing is, of course, blaming your colleague and giving a bad rep to the colleague, but the other thing is that the patient having to face the guilt, or the attenders or the family, that they went to a doctor who didn't do well for their family member. So there's no point telling the patient that the surgeon had a complication, look how bad the surgery is. So there's no point really, because that just brings in a lot of unhappiness for the patient psychologically. So I never say that. I just say that, look, you have a difficult anatomy, and anybody, I would have probably had the same problem, and now let's fix it. So that's how we go with it. And if it's a case referred, of course, we always communicate. But even if it's a case that's not referred, so I would try to get the referral doctor, the doctor's details from the whatever prescription they have, and later on message or call them and say, hey, look, you put this is uveitis, it's not recommended to put a multifocal and stuff like that. Most of the doctors to whom I get back, they do appreciate it. So they don't take it otherwise. And of course, sometimes then they request us that please don't say this to the patient. So I say that I've anyway not said this to the patient. So that part is fine. But more for not even for the referral doctors self, but for the patient, I never let them feel that they've had a complication and somebody's messed up their eye. So I never want them to feel that, because the guilt they have that they didn't do well for their patient, or they're the patient that, oh my God, मेरी तो किस्मत इतनी खराब है, and I'm doomed and my fate is bad. So these are very negative thoughts and they just can't come out of it. And that sadness, that depression goes into them. So you can't heal them. So you have to be their doctor in all ways that you can.
Thank you, ma'am. Dr. Rishi Swarup sir and Dr. Himanshu Mehta sir, any closing thoughts on this as far as professional ethics are concerned?
So I think I would totally agree with Dr. Somashela with her approach. That's exactly my approach. I also get a lot of referrals for corneal decompensations. See, especially when I'm talking about corneal decompensation, you have to understand that most of the people who have these complications have actually got a problem in the cornea. Many of them have got data which could predispose them for this kind of a problem. So especially if I'm seeing something in the fellow eye, I show it to them that, your other eye also is showing some weakness. If I were to do the same surgery, in all likelihood, even I might have landed up in the same situation. And if I actually know the person, like Dr. Somashela mentioned, I would certainly want to communicate with the primary surgeon so that the what is communicated to the patient is not very different, because that really erodes the trust that patients have in doctors as a whole. And we are already dealing with that kind of a crisis right now in this world. So definitely never badmouth your colleague, even if you feel that they are in the wrong. Maybe you can downplay it significantly, because ultimately that's going to serve no purpose, like was mentioned. You have to, your communication has to be positive. So in fact, if it's my own complication, I will be much more upfront compared to if it's my colleague's complication, I will downplay it, because there's really no point going there. And ultimately you have to help the patient come out of it, and that's more important at that point in time. And if you can help them, and then after you fix the problem, if you send them back to the primary physician and tell them that I think it's important to also go and show your doctor, because ultimately he will also be concerned about it. That goes a long way in creating a lot of goodwill with the referring doctor or the primary doctor as well as the patient. It kind of heals that mistrust that was built.
Yeah, I think I wouldn't add anything great to that. It's fantastic. Everything has been laid down so beautifully, to the extent that I tell them it is here and now. I'm seeing you right now. I had no idea where you were. That is past. I've never seen you in the past. I'm seeing you today. I might have done the same thing as what that surgeon did. But let's not talk about what happened, because a lot of patients want you to keep telling them that the other doctor was wrong. Don't walk into the trap. Don't blame anybody. They want you to, they'll stimulate you to say, udhar galti hua tha. You don't want to do that. You don't want to fall into that trap. Whatever happened was for your good. Incidentally, this is where you are. As of today, I can see this. I have no right to comment about the past when I was not there. I was not there at the time of your surgery, so I cannot comment whether anything went wrong. This is how I start. I can tell you only one thing with one more patient, that, a couple of them I tried to save the colleague. The patient thought I never understood. I'm an idiot. I don't understand ophthalmology. They left me with a bad comment, but so be it. But as long as the whole thing goes, I was not there. Of course, I was not there at that surgery. I'm not saying anything wrong. Have I seen you in the past? I have not seen you. So I'm not lying anywhere. I'm telling that there is a problem. You need to catch up with it. Let's work on it. The results should be good. Don't worry. You will be doing very well. At that point, I have nothing more to say. So that's the way to go about with it.